Dr. Jennifer Tufts screwed over Lindsay Clancy, and Reddington was there for it. I feel bad for her. I feel very bad for her. I think her career is going to be in shambles. She kind of brought some of it on herself. She acted like a bit of a petulant teenager on the stand, did not do herself any favors. There's a lot to cover here, and there's a lot of damning information, and poor Lindsay Clancy. Just put it that way. Let's get into it. If you're new here, I'm Annette Lyon, USA Today bestselling author of the suspense novel Just One More and a whole bunch of other stuff. I am a Latter-day Saint as well as a true crime junkie, and oftentimes those two things intersect here at True Crime Faith and Chocolate. Today we're talking more about the Lindsay Clancy trial, specifically Dr. Jennifer Tufts' testimony from Friday into Monday, ending week 2 into week 3 with direct and cross examinations. This is fascinating and disturbing. So we're going to blow through a lot of it. There's a lot of information, but I think a lot of it is also very relevant to understanding where Lindsay Clancy ended up and how she got there. They say, well, how long have you been practicing on your own as a psychiatrist? And she says, almost 4 years now. If you do the math, then, they clarified that at the time that she had her first appointment with Lindsay Clancy, she had been on her own for a month as a doctor. Now, yes, she had graduated from medical school 4 years before that, had a 4-year residency in psychiatry, but that was under an attending physician. She had only been on her own, fully licensed, for a month when Lindsay entered her life, and she had never had a patient with postpartum psychosis. So that's loads of fun. Reddington on cross. I'm going to be mixing both direct and cross here because there's so much information. To me, the less redundant way, hopefully. But on cross, he clarified that her residency happened largely during COVID, which meant doing a lot of telehealth visits, which is now kind of the norm in a lot of medicine, but it hadn't really happened much before that. He also mentioned that labor and delivery nurses, which is what Lindsay was, had to be in person. You can't virtually deliver a baby. She's kind of comparing Lindsay Clancy and Dr. Tufts as providers. My guess is that because that's how Dr. Tufts learned to be a psychiatrist, that she to this day doesn't fully grasp that sometimes you need to see someone in person to fully get a good evaluation. We'll get into some more of that in a second. Reddington also says that she kind of portrayed herself as an expert in the postpartum psychiatry arena, and that's why Lindsay sought her out, because on the website for their clinic, she says that that's what she does. It's a special interest, and she also apparently did an elective during her residency for about a year, part-time, but for about a year with postpartum patients. He asks, is she an expert in postpartum psychiatry? She says, no, that actually isn't really a thing. He asks, have you done any continuing education to educate yourself on all of that and gone to symposiums, whatever? She says, no, but I read a lot of articles. It came across as like she doesn't know what she's talking about, actually. On the self-reporting intake forms, which is, like she said, somewhere between 10 and 20 pages long, that Lindsay had to fill out before their first appointment in September of 2022. She says there were no signs of bipolar or psychosis. I'm going to say these words, probably bleep them, but from here on, I'll say SI and HI. No ideation or ideation. Because SIHI, that's relevant, of course, later. And there was none of that. I'm like, yeah, we were 4 months out. Duh. She was just dealing with the postpartum anxiety at this point and depression. She talks about the different warning signs of bipolar and psychosis, but none of which were present. They were all normal for her in the first visit as well as many after. She says appearance was always fine. Like she was dressed appropriately or whatever. Here's the thing. You can fake that. Even if you're in psychosis, you can fake that on some level. Also, she only saw Lindsay about as much as you're seeing. You guys have no idea if I'm wearing shoes or socks or pants. You could look appropriate from the shoulders up. You have no idea what's going on below that. She also said psychomotor movements were normal. What movements specifically is she observing from the shoulders up? Yeah, you can't see much of the body and how it's moving. Give me a break. We're not seeing them. And then Reddington also points out things like, well, could you see if she was wringing her hands, if a leg was bouncing? And then she's like, well, not necessarily, of course, but sometimes bouncing legs can radiate elsewhere. I have been on Zoom calls where ADHD, sometimes I have to move if I've been sitting in one position too long, and I will have a leg bouncing, not out of anxiety, but just because I need to move. And I can make sure that my whole body isn't moving, that whoever I'm talking to doesn't know. She wouldn't necessarily see those things. She also says other symptoms, talking fast. Like, okay, define fast. What's the baseline compared to what?
And what would you see physically?
So I might see that the person is talking very fast, and it's almost impossible to interrupt their rate of speech. And it might also be very loud. They might be hyperactive, not able to sit still. They might be yelling and jumping from one thought to another without any linear connection between the thoughts. They might, I guess that's probably what I would observe in terms of behaviors.
Basically, a lot of what she talks about could be categorized as ADHD. Like, it's hard to interrupt someone because they're talking so fast and they're jumping from one topic to the other and they're not connected. I'm like, okay, if you were to watch my sisters and me talk to each other based on this description, we would look psychotic. But we know how to interrupt one another because we grew up together. We know our tells. And we also know that one topic was sparked by something else, and it'll probably come around full circle in a second. But even if I don't know how my sister came up with this topic from what I said, I know there was a connection in her head on some level. So there's just so many things. You're describing ADHD more than anything. Come on. And also disordered thoughts. That's such a broad term. She's not being very specific on what that means. That's more like the delusion type stuff, which I know since I've learned about some of this crap, but she's not very good. Much of the criteria for bipolar and or psychosis, you can't tell via telehealth, in my opinion. Reddington also asked her on cross if she had did the Edinburgh scale on Lindsay, which apparently is one specifically targeted at looking at postpartum mental disorders. She didn't even know what it was. That's a problem. Despite the postpartum era period being a special interest for her, she had never heard of the Edinburgh scale. Okay, and instead she used some other test or scale that just screens for depression in general, which would not necessarily catch a postpartum connection because the hormones are what's going crazy. So to her, it's like, well, if it's in the postpartum like 1 year, then would know that there are specifics to the postpartum depression, anxiety, psychosis that are even things like the hormone fluctuations after you wean. Hormone fluctuations can hit, and psychosis can happen right after you wean or shortly after. Lindsay had weaned in like October, and then that's all of this happened in January. It lines up, guys. Oh, okay. Tufts also mentions that the goals with this is so dumb. The goals that they set were to reduce symptoms and to increase functioning. Those aren't goals. That's a wish list. A goal is something you can measure. To sleep X amount of hours at night. Because not sleeping was one of her big concerns. And also not sleeping is a huge red flag and warning sign for impending psychosis. We needed something more specific. Like what would it look like to be functioning? Okay, that you can get out of bed easier, you can fall asleep and stay asleep, that you don't have these racing thoughts, that whatever. Like, we needed a measurable something, not just better functioning, less symptomatic stuff. Like, come on. She diagnosed Lindsay with generalized anxiety disorder with an adjustment disorder and depressive symptoms, but not actual depression, because that makes sense. So she gave her a prescription for Zoloft, either at the first or the second visit, but Lindsay didn't take it at first. She was still breastfeeding, didn't want to risk that. And she was concerned about side effects and that kind of thing. Now, Reddington laid into her on cross about this. One of her biggest concerns was that she couldn't sleep. And one of the side effects from Zoloft is insomnia. Why would you do that? And also, if there could be any indication that someone maybe has an underlying bipolar condition, then an SSRI could really trigger that. And of course, Dr. Tufts was like, what? No. Before she left, they finished the telehealth appointment, the resources she was given was, here are some links on the internet. And that's basically it. Oh, and go to the ER if you need to. That was basically it. The second appointment was also in September, a week or two later. By this point, Tufts is describing Lindsay as having poor insight. And that is consistent for the rest of the 13 other appointments. She saw her 14 times, all telehealth, from September to January. That's a lot. She describes this poor insight as Lindsay didn't want to take meds. Okay. Later on, the poor insight is that Lindsay was blaming one of the medications for making her depression worse, which we'll get. I mean, she had so many weird things going on with her medications that I don't blame her for thinking that, but I think it was a shifting in medications that was making things worse. Now, one big misstep the prosecution made here when it came to their direct examination of Tufts is that they brought up the fact that she didn't do blood work on Lindsay. And if she hadn't brought that up, Reddington couldn't have used that fact on cross to then skewer Tufts by saying, you did not even do basic blood work to check for all of these other things. You didn't do a full workup to see what was really wrong, which I thought was pretty hilarious. That appointment, it was 25 minutes long. 17 of them were listed as therapy. So he goes, well, what does that consist of? So the other minutes were like, discuss medications and how are we feeling, blah, blah, blah. 17 minutes for therapy.
So I provided emotional support and validation and
What does that mean? Validation?
encouragement.
What does that mean?
Something like, I understand this is a very difficult time. It really, it varies on the individual.
Sure. How about Lindsay?
I don't remember the exact therapeutic words that I used.
Okay. How long did you give the therapy? Validation and all that stuff?
I don't remember exactly the duration.
About 10 minutes?
Maybe.
Through the television, right?
Through the computer.
I'm thinking that sounds like a best friend, not a medical doctor. She sounded kind of dumb answering it because it didn't sound like therapy. Especially, it sounded like you could just give anybody that script and have them read it aloud. And I'm like, seriously, you went to medical school for this? That's therapeutic. She wasn't sure which therapeutic words she used with Lindsay. Okay. She recommended that Lindsay see a therapist at the same clinic, also named Jennifer, but McAllister, weekly. The prosecution loved to say that she had only ever done 2 appointments with a therapist, which is true. I believe they were both in October. The problem, though, is she was seeing Tufts so often, and then she had a couple of hospitalizations in the middle, plus the holidays. There was a lot going on, not to mention just keeping her life even minimally functional during all of this. After that second appointment, Lindsay requested a form to extend her maternity leave. She didn't feel like she was in a place where she could take care of patients as early as November. Now, Dr. Tufts was like, oh, well, I can't really fill that out without you being with me, or like, a telehealth appointment, because it's kind of complicated. I think she just wanted another appointment because then they can bill insurance and whatever. It's always about money, in my opinion. So she has another appointment. This one was the third appointment on October 3rd, which was 5 days or so after the second one. And she was begging for more time. And Dr. Tufts said, well, she could advocate for herself. She was medically sophisticated.
And she only took the medication when she decided she was ready to take it, correct?
Yes.
So she was taking in the information you gave her, correct?
Yes.
She was making her own decisions, correct?
Yes.
She was not forced to, correct?
Yes.
She actually had an appointment in between when you first prescribed it and when she started taking it, where she was still discussing with you whether or not she wanted to take it. Is that correct?
Yes.
Is that part of the advocating for herself that you were talking about?
Yes.
Is that part of the medical sophistication that she possessed that you were talking about?
Yes.
Yeah. So she actually said when patients are able to advocate for themselves and share their medical history, we rely on what they tell us. And I kept thinking, well, maybe you shouldn't. Just because Lindsay was a nurse does not mean she knows crap about psychiatric medicine. Those are very different animals. In fact, Reddington made a real point. He brought up a medication used in labor and delivery, and Dr. Tufts had no idea what it was. Understandably so. Kind of like I'm a writer. I've done a lot of professional editing. There are certain things I'm good at. I've done a lot of professional editing, but it's mostly fiction. I would not feel comfortable using a style guide from, the psychological association or some other sciencey thing. That's not my trained skill set. So Lindsay Clancy is a nurse, not a psychiatrist. And she was doing research at home, all these Google searches, trying to advocate for herself to figure out these medications and side effects. But meanwhile, Dr. Tufts is assuming that Lindsay just knows stuff. She's assuming way too much and putting way too much responsibility for her own care on Lindsay's shoulders, which has been crazy. But Lindsay, because I think largely because of the breastfeeding thing, wanted to try therapy before medication, only managed those 2 visits. Reddington and Cross made a point of hammering that Lindsay should not have had to be a perfect advocate for herself. The Dr. Tufts shouldn't have assumed that she was. Why does Lindsay have to volunteer information? That's bonkers to just assume that any relevant information will just be volunteered from the patient. The patient doesn't know the magic words. The patient doesn't know the checklist that the doctor is looking at mentally or literally or on the computer screen to go, okay, what's wrong with this person? And they're listening for like a very specific set of words. And if the patient doesn't happen to know those magic words, oh, well, you must not have X, Y, and Z. No. Also, patients, even when they're completely lucid, and even if they're being completely honest, will probably miss relevant information. They will have forgotten a symptom from a certain day or a pattern or whatever it might be. They're not going to remember everything. So just to trust that a patient will regurgitate everything like a perfect computer download on request is bonkers. 4th appointment was a couple of weeks after that, October 20th. At this point, she's not seeing her too often, every week or two, but she's worse. And this is the point where she first starts having SI. Or at least, Tufts says it wasn't SI. It was worrying about, thinking about SI.
Did you ask her about any thoughts of being close to having thoughts of suicide?
Yes.
Did she indicate to you that she had any thoughts of suicide at all?
Not at that date.
Did she use those words, or is that a box that you checked off?
I don't remember her exact words, but we talked about or, thoughts of hurting yourself.
Right. And there's a distinction between, in your records and the notation, between suicidal ideation and I quote, worrying about, thinking about suicide. Would you agree with that?
Which to me is a distinction without a difference. To me, that's dumb. If she is like constantly ruminating on, oh no, what if I'm going to start having these horrible thoughts? She's having the thoughts. But the way Tufts describe it is, oh, she was afraid that this would happen, so that's a negative. Therefore, it didn't happen. It doesn't count. Okay, sure.
Yes.
And what did she mean when she told you, as her doctor, that she was worrying about, thinking about?
You mean in the prior appointment?
I'm talking about a woman that's sitting in front of you on your television or your computer, telling you that she was worried about, thinking about.
On the second, she didn't say that.
He also tried to point out that there's a black box warning on Zoloft because younger people do have an increased risk of SI on those medications. But at this point, the black box limits it to 24. And Lindsay was, of course, a little bit older, like 32, I think. And there's not a lot of evidence that shows that. But at the same time, I kind of agree with him in that just you don't turn 24 and poof, everything changes in your brain. It's going to be a gradual thing and it will vary person to person. So we don't know. I really think, though, that Dr. Tufts does not grasp that very clear-cut definitions and criteria are not helpful in psychiatry. She needs to just not rely on that kind of thing. It was a disappointment when Lindsay was saying that the Zoloft made me worse. She'd been taking it for a week finally, and she just apparently bumped up to the next dose. And since it was doing worse, Tufts said, just stop it. Don't take any more of it. Dumb. Now, granted, the Zoloft hadn't been in her system terribly long, not long enough to give the benefit. But if you're already seeing a bad side effect, let's stop it. However, even that short of a time, you should titrate off. And I know some of this from personal experience, alas, that like there was one medication that I thought it was a low enough dose. I thought I was doing better and I wouldn't need that anymore. So I just went off. And within like 3 or 4 days, it was bad. maybe skip a dose every 3 days, and then maybe every 2 days, and then you cut back very slowly so your body has a chance to adjust, and that's only if you're already stable or you're replacing it with something else. I find it mind-boggling that she was taking her off one SSRI cold turkey and not bringing on something else to help in that area. Only anti-anxiety meds. It's bizarre. The prosecution also was claiming that Lindsay wasn't close to her in-laws. I don't know why they tried to claim that, especially because we've already heard some of Lindsay's journals where she was listing all these things she was grateful for, trying again, like to manifest goodness and have mental health that was positive. She expressed gratitude for her mother-in-law for being such a support and for, recommending places that she could get help. And despite having the father-in-law on the stand, he seemed to be very warm and affectionate toward her despite what she's done. At one point, also in this, discussing this appointment, Dr. Tuff says, well, she was very depressed. And that jumped out at me because I thought, hold up. A psychiatrist of all people should be able to say she had depression, not just that she was depressed. But she didn't view it as she has depression. She just wasn't feeling well. She just was miserable. She wasn't feeling good. Fifth appointment, October 21st, the very next day. So now we're ramping up on frequency. She had no sleep the night before. Massive red flag for potential psychosis or bipolar. But she didn't appear hyper or manic and didn't report any manic episodes from her past. Patients might not think to report something that's relevant that could be considered a manic episode, because to them, the manic thing might have just been, I finally had energy to do X, Y, and Z. And they might not realize it was a manic episode until years later or until someone else points it out. I've seen that happen. So it's bizarre to me that, oh yeah, I've never had a manic episode. And Tufts goes, okay. Make it make sense. At this point, she prescribed Ativan, which is anti-anxiety medication, as needed for about a week. So to help her with the anxiety. On the sixth appointment, 5 days later, it said that Ativan had helped with the anxiety, but not sleep. And so on her own, Lindsay had added Benadryl to help her sleep, and it had helped. So just for gee whiz, Tylenol PM, it's just Tylenol with Benadryl. So Benadryl makes a lot of people sleepy. It doesn't for me. So at this point, she had 3 prescriptions. Ativan for it's kind of a strong anti-anxiety, Buspar, which she added, which is a mild anti-anxiety, and that she was supposed to take every day. We have some family experience with that one. But if it wasn't enough, she could then add the Ativan in extreme moments. And then she had this prescription antihistamine, which has been used for anti-anxiety, to replace the Benadryl. She didn't explain this part, but I happen to know that long-term use of Benadryl can lead to brain issues like dementia. So she might have just wanted to steer clear of that, but she didn't actually say that. She wasn't a great witness. Now, at this point, we have not heard any concerns about benzo addiction, which we find a repeated pattern after this appointment. But up to this point, the biggest concern was SSRIs and breastfeeding. She's no longer breastfeeding. And the SSRIs, it sounds like she wasn't so much concerned about them with that, except that she thinks they're making her worse. But the benzo addiction thing starts now. And it sounds like it's Tufts' fault. She's the one who brought up, oh, well, you don't want to be Ativan for a really long time because it can be really hard to get off. You can get addicted to it and become dependent. She hadn't been on it for more than a week. That is not long enough for someone to be dependent on it, but she wanted to already taper her off. How about we get her stable first, get her sleeping regularly, and then we'll look at it. But after a week, she was still in crisis. What are you thinking? That's bonkers. Also, Reddington points out on cross that Ativan is contraindicated with use with Benadryl because they're both nervous system depressants. And she's like, well, yeah, but whatever. So the next appointment was a week later on November 2nd. Lindsay was afraid to take the Buspar, probably because, oh my gosh, of dependence. But Buspar is supposed to be an everyday medication. I think that's why she was afraid of it, even though it was a milder one. But she'd been using just the Ativan. Apparently, there's no record in the medical records about whether they talked about Benadryl or the other prescription antihistamine. They discussed replacing Ativan with something else due to the dependency. The Tufts is the one that brought up. So this really does feel like Lindsay is starting to get worried about benzo addiction. And I think that might have been taking her on and off benzos might have been what pushed her over the edge, in my non-scientific, non-professional opinion. So they're discussing tapering Ativan, which I'm thinking, yet is so dumb when she's not stable. She hasn't been taking it long enough to be addicted. Almost 3 weeks later is when she has her 8th appointment. In between there, though, she went to Rhode Island into the hospital down there called South Shore. So she gets a Prozac prescription while she's at South Shore, and she's using Benadryl and the Ativan together to help her sleep. And in my opinion, smart woman, because she knows she needs to sleep. She didn't do the Ativan taper, which Tess was like, oh, you need to do this. But she didn't want to go back to work again quite yet. She didn't feel like she was ready for that. Even so, Tufts sent an authorization to go back to work, but not immediately. On cross, Reddington then pointed out that Lindsay had actually called a helpline twice.
How about suicide hotlines? Do you give them advice to call them?
That's an option as well, yes.
Sure. Did she call suicide hotlines?
I was not aware that she did.
Did you ever ask her?
I don't think I specifically asked that question.
Not specifically. Did you ask her anything? Did you beat around the bush maybe? You ask her anything about suicide hotlines?
I don't think I asked her about suicide hotlines.
Would it surprise you to know that she called suicide hotline in that time frame, not once, but twice, and was turned away? You guys were in the front line of this, aren't you?
No, overall.
It does surprise me, yes.
It does what?
It surprises me that she called them twice.
And you never asked her if she had ever called the suicide hotline, did you?
I don't think that I did.
Tufts never knew. And Tufts was supposedly on the front lines of Lindsay's issues and had no clue about any of that. 1 week later, on December 2nd, we have the 9th appointment. At this point, Dr. Tufts says, oh, I wasn't her primary psychiatrist anymore. I was just more in of a supporting role. And yet she's still prescribing, which is, yeah. So Lindsay was not getting better. That she tried to taper the Ativan, but she couldn't sleep. No, duh, doctor. Like, you shouldn't have ever told her to taper the Ativan yet. She wasn't stable yet. Ugh. At South Shore, though, here's what was going on there. She had trazodone prescribed, did not get much relief from that. It's mostly for anxiety and sleep, but it's technically under the antidepressant category. Ativan, then the Benadryl and the Prozac were the ones that she was taking with South Shore, but the Prozac made the depression worse, and she had worse sleep, probably because of the Prozac. They talked about Remeron, which is another antidepressant, and Klonopin, which is another stronger anti-anxiety. She went on the Remeron, but did not take the Seroquel yet. So apparently a Seroquel is at a lower dose is more of an antidepressant. At a higher dose, it sounds like it's an antipsychotic. And people freak out over the psychosis labels, but anything that affects the brain often is used different things. A lot of medications that were originally developed for epilepsy are now used for migraine prevention. So there's a lot of overlap in brain stuff. Remeron, that's when she first starts having intrusive thoughts about death specifically. She went to the ER due to SI. And then we have a whole discussion about the importance of sticking to a medical psychiatric plan and only have one person prescribe medication. Okay, Dr. Tufts, what are we doing? Because, yeah, you were still prescribing. Get a clue. Huh. So, but a very bad answer. It's like, why is it important to stick with the plan? Well, because it's a plan and we should stick to it. It was a really dumb answer. But when it comes to psychiatric meds, you would think she would say, because there are so many possible bad things that can go wrong if you're not on the same page. And it's best to be on one page with one person and then make sure everybody knows what's going on. I mean, she did not explain that, like, oh, because if you're messing with your brain chemistry, going on and off things, and you don't know what's actually in the brain, you could have bipolar rapid cycling or manic mixed episodes, or none of that stuff. None of that. She didn't say any of that. And once more, I felt like Dr. Tufts is just too by the book when it comes to criteria of like, well, it's not mania because it didn't last this exact number of days, and drives me crazy. And that nurse practitioner, Gillette, I think, was the only provider to really take that red flag seriously. She has another appointment at South Shore the very next day, which would be December 3rd. And so Tufts says, hey, well, you know what? Maybe you could ask them about lamotrigine. Ask your new provider about that. Mind-bogglingly, she never asked for a HIPAA release to allow her to see the records from her hospitalization, from South Shore, from anywhere else, which is completely bonkers to me because, especially in psychiatry, there are so many moving pieces. And again, to be on the same same page with your patient. You need to know what other people have been doing. But she never requested it. And she kept saying, oh, I didn't have access to those records because we're in a different clinic system or hospital system. You could have gotten them with a request. Lindsay absolutely would have signed a release. I don't know why you wouldn't do that, especially for a patient who's so clearly acute. Okay, 10th appointment, December 16th, about a week later. She's taking Valium, which is the generic is diazepam and Seroquel. She's finally sleeping, but having a really rough time emotionally. This ideation and depression are worse. Now she's feeling hopeless, and this is the part that kills me. She has no plan for S, but she has SI, and she goes to the ER, and she's turned away. And she thinks the Seroquel is making it worse. Now here's the part that blows my mind, because she had called the S helpline twice. She went to the ER at least twice, I believe, kept being turned away because she didn't have a plan. By the time someone has a distinct plan, it's probably too late. I hate that that's the system. And it's not just the US system. It's not just Massachusetts. I know someone who works in a foster care type, a youth home in a completely different jurisdiction, and they've had the same thing. If they have a teenager who has tried to self-harm, and that way they can go to the hospital. And if they have they no longer in that exact moment want to off themselves, then they have to be released, but they're still at risk. It could be another hour and they're doing it again. I don't know what the answer is here, but it's really sad. And also the fact that if psychosis is coming down the pike, it can snap again like a switch so quickly that, oh, now I have a plan. It's too late. It's just too late. At this point, the South Shore people are saying, well, let's taper off the Valium. And I think that they in previous testimony, it sounded like they wanted to do that because Lindsay was afraid of a benzo dependency. Again, because Tufts is the one who brought that up in October. Why? So they're like, well, okay, we'll support a Valium taper. And then Tufts hears about that and goes, yeah, I'll support the Valium taper. But this was all Lindsay's idea. It wasn't a good idea to begin with. Dr. Tufts prescribes Lamictal, so much for being in a supporting role, whatever. And she did not communicate with South Shore again, did not even tell them that she had prescribed a new medication. She goes, oh, I assumed that Lindsay would tell her new doctors that I had prescribed something else. Okay, what was that about being on the same page and having just one provider and so everybody knows what's going on? Come on. So 2 weeks later, we have appointment number 11. In the meantime, we had the holidays, Christmas and New Year's, and on New Year's Eve, they decided that it's time to go to the psych ward. And then that's when she got absolute crap care for like 4 days. And then she comes out. Supposedly, according to Tufts, she went to the hospital to taper off of Seroquel safely. Since when, apparently, does Tufts think that that's a thing? Because she said to go cold turkey off with Zoloft, but whatever. But she was only there for 4 days. It doesn't sound like she was going there to taper off or that she did taper off. It just sounds like she was there and was doing puzzles and playing with Play-Doh and going on walks, but didn't really get much care. And Patrick complained that she wasn't getting care. So the plan coming out of the hospital at this second appointment here on January 6th was to up the trazodone, even though trazodone hadn't helped much, monitor her depression now that she's off the Seroquel, because they thought she and Patrick thought the Seroquel was making things worse. Here's the thing that's frustrating me too. So she was never on an antidepressant long enough for it to do what it needed to do. She had it in her body just long enough for it to mess with her brain and then to just go off of it and that would mess with her brain again. And she goes on another one that messes her brain in a different way. And then she goes off of that one. No wonder her brain was like, okay, uncle, I can't handle this. There was a point where the record says that Lindsay was quote unquote deteriorating. And Reddington jumped on that. And on the one hand, it sounded good, but that's the one time I'm like, Reddington, come on, because she only had 3 options in the drop it down boxes. It was either she's improving the same or getting worse, and deteriorating is the word they used. But Reddington did make a good point that there's a lot of stuff that she clicks and stuff just because it's a drop down box, and she could have entered her own notes, but she was too reliant again on the clicky system and the exact criteria of whatever. There's no nuance for her. The prosecution says if the patient withholds information, then the doctor can't treat them very well, right? Right. Which is exactly why she should have requested a HIPAA release and then found records from the other providers and maybe talked to her parents and to Patrick more and other people to try to get a full picture, because she was missing the whole picture. 3 days later, we get appointment number 12. She's tolerating the higher dose of trazodone. She's still getting rebound anxiety from the Ativan. Rebound anxiety being that in the morning after it's worn off, anxiety is even worse than before. On January 9th, her mood's okay, but her affect is completely flat. She can't even cry. She can't really feel anything or do anything, but there's no sign of psychosis. She's clearly getting worse. But okay, whatever. There was discussion of maybe adding another SSRI into the mix, since clearly Seroquel wasn't the factor. No prescription, just talk. And I'm thinking, with the Zoloft, you gave her the prescription. She didn't take it for a couple of weeks, but then she did. So why not we give her a prescription and let her take it when she's ready? There's an idea, but no. So they talked about both Wellbutrin and amitriptyline. Eventually, they tried the amitriptyline. The Valium taper was prescribed. Again, we're talking about dependency. And I'm thinking, why are we doing this again? Can we just stop? 2 days later, Lindsay is sending messages through the portal asking about getting ketamine therapy, because that is very effective for people who have SI and who have treatment-resistant depression. But the doctor says, oh, well, it's possible for an option later on, but insurance companies rarely cover it unless you've tried 4 SSRIs already. And party wants to go, yay, Merca, our medical system sucks. Insurance companies shouldn't be able to make those calls. I hate it. Hate it so bad. The appointment number 13 was on January 16th, 5 days after the messages and about a week after her last online appointment. And at this point, Lindsay is saying, I can do the basics about life. I get out of bed and just go through the motions of taking care of her kids, but it feels forced. She's 1 week into the Valium taper, which should not have happened, in my opinion. And they're adding the amitriptyline finally. 1 week later, 1 day before the deaths, she has her final appointment. She is very depressed, has a flat affect still, and she had for a couple weeks at this point. She's still tapering off the Valium. But so her heart is racing, her anxiety is ramped up. Gee, I wonder why. Could it be that you're ramping down on the Valium, taking away the medication that's actually helping her function? I don't know. And there's no clear signs of psychosis, but it's clearly around the corner. Her heart is racing, her anxiety is through the roof. Come on, can we see the clues? Can we see the signs? So the plan was to slow the Valium taper and to increase the amitriptyline. Reddington Uncross brings up alcohol use, which is on the intake form. Lindsay said she was taking alcohol, drinking like up to 2 drinks a night, 5 days a week, and felt guilty about it because it was a way to numb up her anxiety. They never talked about it. She's like, well, she wasn't an alcoholic. And he's like, yeah, but she expressed concern about it. She was worried and felt guilty about it. And she was using the alcohol as medication. Why did you not bring it up? Just didn't. Okay. One of the most beautiful moments was the way he ended his final cross, because they, of course, they have direct, cross, redirect, recross. So this is the end of the recross. He brings out some of her notes. I believe this is an October appointment. Watch this.
Can you just read this paragraph here for us?
No sleep last night. Falls asleep after 40 minutes. Heart racing, severe anxiety. Worrying about kids, baby, sleep. Yawns, but not drowsy. Not hyper, pressured speech.
What was that? What?
Not hyper, not pressured speech is what I meant. I know it doesn't say not, but that is exactly what I meant.
Wait, when did you see this that you noticed that it did not say not?
I don't care what it says. I know what I meant.
Well, when you wrote this, you did not say not pressured speech. You said in the medical record, pressured speech, right?
No.
Does it say that?
Yeah, the word is the word not is right before not hyper, comma, pressured speech.
Right.
The two
So
are following
what
the
does comma mean
not.
to you? When you put down in a medical record, heart racing, comma, severe anxiety, comma, worried about kids, comma, baby, comma, sleep, comma, yawns, but not drowsy, period. Not hyper, comma, pressured speech. That's what you wrote, right?
She did not have pressured speech.
Doctor.
I wrote that, but you're misinterpreting my note.
Am I reading this correctly, and the jury will be able to look at it, that you put not hyper, comma, pressured speech? Did I read that right?
Yes, but your interpretation is incorrect.
As opposed to yours?
Yes, but your interpretation is incorrect.
As opposed to yours? That's all I have.
The Commonwealth would move to submit the certified.
I totally see her point. and yet she looks like an idiot. Also, you need to be much more careful when you're making medical records. I've seen people commenting on it online saying things like, you keep your medical records pristine as if they will be subpoenaed in court someday or read in court someday. Hi, yeah, hard lesson learned. But the way she even stormed out of the room, she looked pissed. And that was not a good look. That was just not a good look. So do I think that Jennifer Tufts is completely at fault for all of what happened? Absolutely not. But she was a big factor, I think, in Lindsay not getting the care she needed and creating the worry about the benzo issue. So many issues, letting her go on and off SSRIs, Lindsay's version of SI and saying, nope, that doesn't count. Lindsay's red flags of mania and insomnia. Nope, it hasn't been long enough according to the DSM. So nope, we'll just do another SSRI. I think Tufts wants to think she's smarter and more experienced and better at this than she is, in my opinion. We'll cover week 3 soon, but let me know what you think as we move into week 4. This is it's a crazy trial. It is absolutely crazy and heartbreaking. And let's remember Cora, Dawson, and Callan while we're here, those precious little children whose lives were taken much too quickly. Let me know what you think. Be respectful, please. Like, share, subscribe, all those good things. And we'll see you next time.